So when they asked me that, since I have been giving a lot of talk and had some publications related to acute febrile illness, what should be my message to people and COVID-19 infection? So then I realized that it's a very early stage. Vellore being in Tamil Nadu, a corner of Tamil Nadu where we are not having too many positives so far. I would probably moderate a session which may have experts who do a lot of testing in their laboratory. And fortunately, we got Dr. Sujay and Dr. Anil Handu. Anil Handu and Dr. Sujay are also laboratory hematologists, but they also are directors of laboratories which under one roof do the testing for COVID. So I thought that before I can pass it on to them, can I say that is there a role for a hematologist or a hematology laboratory in a COVID-19 infection? Of course, a small introduction. COVID-19 stands for the coronavirus disease discovered in 2019. It's an RNA virus from animals. Predominant mode is airborne and spread can be through contact, contaminated surfaces, or sometimes fecal-oral routes. People usually present with acute febrile illness, which will be fever, dry cough, fatigue, and dyspnea. Progression can lead to involvement of all organs. Median age of across age and sex is 47. I mean, across sex is 47 years. Median age of severe cases are 63 years, and the severity is somehow related to age people as well as people who have other comorbidities. There is, of course, no vertical transmission to fetus, and as far as blood transmission, which is also my area, there is no transmission transmitted infection known so far. Ultimately, many of these people, when they progress into a frank DIC, leading to almost 2% mortality. Majority actually have only mild disease. So when you have an acute febrile illness and a hematology laboratory in the context of COVID-19, what can a hematology laboratory offer? White cell counts, which is very important for acute febrile illness, which can be obtained from cell counters. ESR, a surrogate marker is CRP. There are many cell counters now which come with these markers. Platelet counts from cell counters. And of course, there are coagulation defects that have been described in patients with COVID. And of course, that can be obtained from coagulometers, which are existing in many hematology laboratories. Interestingly, the coagulation defects start with a hypercoagulable state in these patients. There is a good data that has come from Singapore General Hospital, and that is on clot waveform analysis done on patients who had COVID. And they describe these changes to be reflecting a hypercoagulable state in the plasma when they were doing PT and APTT. Of course, a hypercoagulable state, if it becomes severe and worsens, it goes on to a frank DIC. And as markers of DIC, the prothrombin time is increased. There can be decrease in fibrinogen. And of course, the D-dimer is very highly elevated. So it looks like there is a lot of thrombin generation that is happening in these patients. But that is all for coagulation defect. Let's go on to the cell counters in acute febrile illness. Of course, always white cell counts are very important in acute febrile illness. We can get neutrophilia, like in bacterial infection, lymphocytosis, which can happen in viral infection, monocytosis, which can happen in chronic infections, neutropenia, which can happen in acute bacterial infection like sepsis. Eosinopenia can be a marker of any good infection, severe infection. Only thing is you need to keep a different reference range, which may be applicable to your population. In CMC, our reference range for eosinophils are 200 to 600 instead of 40 to 440 that is being described in most of the literature. Most of the cell counters, the SI unit is 10 raised to the power of 9 per liter. Many of us in laboratory prefer thousands per microliter, which is same as 1000 per cubic millimeter. And of course, lymphocytopenia is also very common in many viral illnesses, especially the community-acquired respiratory viruses. So you have these cell counters, different types of cell counters with different output, which also gives these parameters which I mentioned in the earlier slide, which is the neutrophil count, the lymphocyte count, the monocyte count, and the eosinophil count, and the white cell count. And of course, in addition to that, they also display pictures of how the cell counter has evaluated those cells after processing them. And they also give the suspect flags. So what is the significance of flagging in acute febrile illness from cell counters. We know that flagging generally comes out from abnormal patterns when these cell counter suspects that there's an abnormal population present in an abnormal location. They actually can give a flag for a blast, which can be a myeloblast or a lymphoblast. But we also realize that many systemic diseases process bring about changes in white cells, red cells, and platelets, which are the regular white cells, neutrophils, regular eosinophils, regular lymphocytes. They bring about changes in these cells, and these changes are reflected in its output, but there is no flag. However, these changes are reflected as changes, which is actually reflected as a measure of the cell. The measure of the cell is also called the cell population data, and this is an example of a cell population data which was obtained on 3,000 healthy blood donors, which tell you that what is an average size of a neutrophil, and the distribution of the neutrophil, an average size of a lymphocyte, average size of a monocyte and its distribution, the average other characteristic of a neutrophil like the internal structure, which is conductivity, the granularity of the neutrophil, the average. So this is the reflection of what could be there in a normal human being. And many other centers have also developed cell population data in most of the cell counters, like Beckman Coulter, Mindray, the Sysmex, as well as Horiba. And many of them have compared, and that's fairly comparable. So this cell population data, are they useful in acute febrile illness? Yes. For example, if you look at this 17-year-old male with viral fever, you can see that the white cell counts have gone up, and you can see that there is an abnormal population, a pattern that you can see. So this is the patient, and that's a normal on your right-hand side. What you can see is a normal display on a Mindray cell counter, and you can see that there is a huge population on the hitting the roof of the cube, and those are the abnormal lymphocytes that you see in viral infection. So this is a patient who has got lymphocytosis with abnormal viral lymphocytes, and so this is an example of, and this can be objectively measured as high fluorescent cell percentage. You can see that the cell count is also flagged abnormal lymphoblast, atypical lymphocytes, and also mentioned lymphocytosis. For example, there's another patient who had sepsis. You can see that the neutrophil population, when compared to a normal display, you can see the neutrophils have got very high fluorescence along the the y-axis, and that's mainly because of the changes that happen to the neutrophil during acute bacterial infection, especially sepsis. So, what is a role for a cell counter in COVID? What is already known about COVID from data that has come from China and also from other centers is that white cell counts are important. Many people have reflected leukopenia, but that's not that common. So I don't agree with leukopenia as a marker for COVID. But neutrophilia can be there, but sometimes it can be relative neutrophilia. Eosinopenia is definitely, but eosinopenia is a non-specific marker because a lot of infections are associated with eosinopenia. But what is characteristically mentioned is that patients present with lymphocytopenia. Those people, once they become symptomatic, one of the earliest signs is lymphocytopenia. The reference range for lymphocytes can be 1.4 to 4,400 to 4,800 per cubic millimeter. Some people can put the reference range as 1,000 to 4,000 per cubic millimeter. But when it's children population, obviously you're not starting at 1. It can be 3,000 to 9,000 per cubic millimeter. So anything that's less than 1,000 or 1 into 10 raised to the power of 9 per liter can be defined as lymphocytopenia. But we also notice that the cell counters do also give a percentage, and we as laboratory hematologists also do a differential count on the slide, and we say that the lymphocyte percentage. So the reference range for percentage of lymphocyte is 20 to 40% in a differential count. So what should be considered as lymphocytopenia? Is it the absolute lymphocyte count, which we are not usually used to, or it should be percentage, which we are commonly used to? So do we require this fancy, high-end, fantastic cell counters to identify these simple changes? So lymphocytopenia can be reflected by any cell counter because that's a work of a cell counter. However, when we are using cell counters of these high-end type, we also like to look at cell population data. So yes, fortunately, Mindray had the consultancy of Dr. Raymond Simon, who does indulge in a lot of cell population data of studies. And in his presentation, which he made a few weeks back, he did mention that one of the cell population data that has caught his attention is monocyte EZ on a BC 6800 cell counter, which may be an indirect relationship to the monocyte size. As you know, monocyte EZ is a forward scatter on a monocyte that is shrinking as it's being measured. So, you know, the processing in the Mindray cell counter is that the cells are, they put a pore into the cell and they allow the dye to get in. By the time the cell starts shrinking, but the analysis is done before it completely shrinks. So it can be assumed to be significant as the processing rate or transit time in a BC 6800 plus is faster than usually other cell counters. So maybe it's probably reflecting the real-time measurement of the monocyte size. However, there is no scattergram morphology that we saw in a patient with dengue that I showed you earlier, where there is a lymphocyte pattern that is very characteristic morphology on a dengue infection. So lymphocytopenia, what are the other values that could be picked up on a cell counter? Maybe not indication of a COVID infection, because lymphocytopenia is not that uncommon in other viral infection, especially the commonly community transmitted respiratory illnesses that happen during certain seasons. So they also present with lymphocytopenia. So it's not a marker of COVID illness or diagnostic of COVID illness, but it can be used to monitor along with other markers which can indicate progression of this condition or prognosis, which can be indicated towards a poor prognosis. So absolute lymphocyte count, if they decrease, it is bad for the patient, and the cutoff is put as 0.63 into 10 raised to the power of 9 per liter. Absolute neutrophils increase, and they also come out with a lot of cell population data changes, which can also happen in other conditions. So in severe cases, the neutrophilia can be more than 7,850 or 7.85 into 10 raised to the power of 9 per liter. And a bad outcome is associated with much higher neutrophil, that's 9.27 into 10 raised to the power of 9 per liter. Of course, what is being talked about is the NLR, neutrophil lymphocyte ratio. So it's going to be very easy because neutrophils are increasing and lymphocytes are decreasing. So if a neutrophil is 3.13 times the lymphocyte in the blood, it indicates that the person needs extra attention. Of course, platelet thrombocytopenia is only seen in very severe cases, otherwise not normally seen. Like when we always look at dengue, we think platelets will drop. Here, we don't have to think that way. And of course, like most of the other conditions, red cell distribution with standard deviation is also found to increase in severe cases. So all this can be picked up on a cell counter. So the issue is whether should we go for absolute lymphocyte count or should we look at percentage? So here I have got 2 patients who have been positive for COVID illness. They were only symptomatic, they were not severe. Here you can see that their white cell count is high, neutrophilia is there. The lymphocyte is definitely 3.13 times lower than neutrophils. But if you look at the absolute lymphocyte count of 1 and less than 1, none of these patients will be called as lymphocytopenia. But if you look at their percentage of 20 and less, both these people can be called as lymphocytopenia. Even the percentage will give you a NLR of 3.13 or more. So you can see that probably percentage may be better because there's a lot of fluctuation of white cell count, which may not give you a lymphocyte, absolute lymphocyte count of less than 1, even in patients with severe COVID illness. So I think a percentage of less than 20% may be more reliable as a marker of lymphocytopenia rather than an absolute lymphocyte count. So do you require these high-end cell counters to identify these parameters? I think maybe not, because if you look at a 3-part cell counters, there's an output from a 3-part cell counters. All of you who work in good laboratories are used to 3-part cell counters. Those who work in remote parts of the country are also used to 3-part cell counters. You can see that if you look at it carefully, the WBC histogram is divided into 3 parts. We are only interested in the first part and the third part. The third part is a neutrophil and the first part is a lymphocyte. And every 3-part cell counter will give you a lymphocyte in percentage or an absolute count. And as I said, we are interested in percentage. So if a person presents with febrile illness, and if you are doing a cell count, maybe those who have lymphocytopenia, where the percentage of lymphocyte less than 20%, can be selected for testing. So this is something that was proposed in our hospital when the testing was not happening to identify patients who have got febrile illness. Maybe those with lymphocytopenia should be sent for testing. So this was, but now that testing has happened rampantly, we don't probably require a screening tool like this, but I would still trust a screening tool like this. So coming back to the fact that there is worsening of condition with absolute lymphocyte count decreasing, increase in absolute neutrophils. Then you have the NLR and platelet counts also picked up on a 3-part cell counter, and a RDWSD, which can also be identified on 3-part cell counter. So a 3-part cell counters can right now provide all that data which is required or which has been indicated as changing in patients who develop COVID infection. So what is the development that is required? Because a lot of people, especially in India, who are chemocytomorphometrists like Anil, who is also going to speak, and of course Dr. Sujay, his lab with Anand Vikas being there. I hope he also identifies some scattergram morphology. Yes, so I think India may come out with some cell population data or scattergram morphology, which may be better than what has been coming out from the rest of the world. So I now hand over to Anil Handu, but I would wish there was a lot of cytomorphometry to be discussed in COVID infection, but I think he is going to talk about more important aspect about laboratory's approach to a patient who presents with COVID infection. Thank you very much.
Thank you, Dr. Sukesh, sir. There have been a lot of questions which are coming on. So before we can invite sir, would you be okay to answer a couple of those questions, sir?
Okay.
Okay.
Let me go to the chat box.
Yes, sir, we will help you with that. Varun, can you talk about the questions that have been coming? One of the question I will read it out to you, sir. So somebody had asked, sir, so is there a difference between SIC, DIC, and CSC?
Yeah, so there is, obviously when we talk about sepsis-induced coagulopathy, we are generally starting with a hypocoagulable state, but there are some DICs which the hypercoagulable state can become very obvious, but we just wait for the evolution of that to happen. Now that generally people will say that hypercoagulable state can be treated, but nobody has taken any approach or randomized trial on that particular aspect, because nobody wants to use convert a person into hypocoagulable state when a DIC is impending. But eventually the pathophysiology of everything turns towards one particular direction, and it leads to end organ damage.
Sir, there's a question from Dr. Dilna Kerala. She has two questions. She's asking, is peripheral smear mandatory in all febrile patients in current scenario, or should we wait for confirmation of community spread by ICMR?
So I think, we are, when I talked about hematology parameters, we are only talking at numbers. We are not talking about any morphology changes. There are some subtle morphology changes which have been there, like increasing size of a monocyte or a lymphocyte, but they are not reflected on regular peripheral blood morphology. I think maybe for research purposes, you can archive a slide, but as long as you have a slide review rule in your laboratory, which encompasses most of the abnormalities, you just need to follow that. You don't need to have a special slide review rule in case of COVID.
So there's one more question. Should we do COVID-19 test in patients with history of fever and differential count showing lymphopenia?
So that's what I said, initially when we were not doing testing, one of the things to identify a potential patient who presents with fever and probably respiratory symptoms is to look at lymphopenia and probably look at him carefully and send his sample for testing. But now that we are doing testing ourselves, we also realize that lymphocytopenia is not a very specific marker, maybe a sensitive marker, because there are many other community respiratory viral illnesses that happen during this particular season, which are associated with lymphocytopenia. But this can be used as a marker of progress and prognosis.
So we take one more last question now, and then we can take others. So one of the question is, higher inflammatory markers like IL-6 seems to be associated with higher mortality. So is IL-6 a marker for more severe disease?
So, you're coming to almost a macrophage activating syndrome, which will be associated with these markers. Yes, severe, obviously we are talking at severe cases here, and there has been a component of macrophage activating syndrome because most of their patients, the ferritin levels are very high. It's an acute phase reactant, but we had just written a paper on potential hypothesis on how to reduce the impact of macrophage activating syndrome by a little bit of plasma exchange. But of course, all these will only reflect towards a macrophage activating syndrome.
So if you can take one more question. So the question is that what precaution to be taken by lab personnel handling CBC sample or a smear preparations?
Can you say that again?
What precaution should be taken by a lab personnel while handling CBC sample and smear preparation?
Oh yeah, so this will be the, routine PP is what is done, which is nothing beyond that. Only thing is, previously when we do the PP, we will be thinking that there's no problem, but this time just think that there is something. So just use the routine PP.
So this was the last question we have received as of now.
Fine.
So once we get
and
more,
I thank everybody for the wishes that they sent. Thank you very much.
thank you. So Nikhil, can you take Dr. Handu on the screen, please?
Hi, so Nikhil, can I just share my screen now?
Yes, sir. Please go ahead, sir. Priyank this side. Yes, sir, it is starting. So we can see your screen, sir.
I'm just starting the slideshow.
Perfect, sir.
So,
We can see it.
good afternoon. And at the outset, I would like to wish Dr. Sukesh Nair many, many happy returns of the day. It's indeed such a pleasure to see you on screen on your birthday. Thank you very much for being a part of this program and taking the moderation as well. Now, my talk today has been put on defining laboratory testing for COVID-19 and pre-screening, screening, and confirmation. So I'll just go right away into the thing. And thanks, Mindray, for having this online seminar. So this is the place where I work. For those of you who don't know, this is BL Kapoor Hospital in Delhi. And we had been designated as a COVID hospital recently, a part of our hospital, but there's been a change in the thought process now. And the administration, the Delhi government has now decided that instead of having a COVID hospital, a part of the hospital as a COVID hospital, you will actually have the entire hospital designated as a COVID one rather than only the part of it. So therefore, we were a part of COVID, and now we are not really a part of the COVID, but yet as a group, we still continue to be a part of the COVID process. All right. So at the outset, I would like to put in a disclaimer that most of the views which are here are only mine, and they have primarily based on the literature which is available on the net. And I'm sure a lot of you would have probably read it also, and I do not have any significant conflicts of interest. Now, the picture which I'm showing in front of you is something which probably will never happen again in our lifetime, I guess. You would sneeze and people would say, God bless you. And that is no longer the reality anymore. What will happen probably now is everybody who looks at you now sneezing, the only thing and the only picture which will come to anybody and everybody's mind is this picture. Mind you, I don't know how many of you realize that this is the most looked at picture, on the internet, at least for the last 2 months now. And it's interesting how this one small little particle has changed our lives. And it has changed our lives to the extent that even the people who are at the helm and who are really trying to look at things and getting things done, they have to actually use helmets like these and scare the people away back into their homes. But that's really what we have in life now, and this is what we have to keep, in our minds. And healthcare people, the people at the front line today are the healthcare professionals, which includes your doctors, your nurses, your GDA staff and other staff, which are actually really at the front line dealing with the patients and trying to, help the patients out in this hour of crisis. And most importantly, when these people are actually really sitting at the forefront and trying to see, the biggest problem which most of us will face will be the overlap of symptomatology between various diseases. That's your coronavirus, the common flu, the cold, etc., which always has an overlapping symptomatology. And therefore, for anyone to really come to a final conclusion, you will have to depend upon nobody else but the laboratory. And that's where the lab's role starts coming into a big way. Obviously, in a laboratory, the first step obviously would be to ensure that we have been sitting across onto the channel in such a way that we are able to decide which test would be appropriate and which would be the best modality to do. We would need to get our logistics in place, ensure that everything is available. We must validate our testing appropriately. And then, of course, the Eureka, the test, which is currently the big test available, that's your RT-PCR test. Everybody wants to do that. And eventually, it is this test, the information from this test, which helps us to guide our clinical colleagues as to whether the person is having COVID or not having COVID. Now, if we define the laboratory testing, the wish list is at 3 levels. One, the people and the patients in general, they want a rapid, a reliable, and a cost-effective test. And we have heard recently, the Honorable Supreme Court wants the test free, and we have already started doing it free across the country. What does the government want? They want a rapid, reliable, and a cost-effective test as well. And of course, from our end, of course, we will not talk about the free part of it, but for sure, we also want a rapid, reliable, and a cost-effective test. So obviously, when we are looking at a test, we're looking at a test which is people or patient-centric. So if we look at the laboratory perspective, it's our ethical obligation to provide an accurate, precise, and a precise test which is available within the shortest possible turnaround time. And as I told you, cost effectively. And more importantly, at the back end, we need to make sure that the environment which is provided for our staff to work is safe. And at the same time, if we could do some research and innovation. Okay, so when we set up a test, what is always playing on our minds? Most of us are laboratory professionals. The first thing that comes to our mind is that we want a test which is highly specific and which is highly sensitive at the same time. Now, most of us will understand that this is not the reality. In reality, you do not have a 100% true positive and a 100% true negative scenario. In other words, you do not have a zero false positivity and a zero false negativity. So in such a scenario, setting up of a test is always a challenge in any laboratory. What if we could get a test like malaria antigen and just put in a drop of blood onto that and see the card and decide, okay, fine, great, we've gotten a positive test and this is corona, and we've got a negative test and this is not corona. Now, if this is how the wishes would be, life would have been much simpler. But how do we design a test? The design comes directly from the structure of the coronavirus. And if you see the coronavirus structure here, you are able to see these envelope. The envelope has these proteins, and within that protein spacious structure, you have the single-stranded RNA. So what all can you target? You can target the proteins, identify an antigen from there, or identify and quantify the antibody in somebody's serum and see whether you're having that antibody against these antigens. Or more specifically, you can go to the single-stranded RNA itself and start looking for a specific sequence on the RNA and get the information as to whether you're dealing with this virus. These are various other nuclear proteins which are shared commonly between coronaviruses. I will not get into details of them. The most important point comes in this particular diagram which you're seeing over here. What's obvious is that the SARS coronavirus is actually a part of a bigger group, which is the beta coronaviruses. And a lot of these proteins are shared by a lot of them. So therefore, actually, if you really go ahead and do only the antigen testing with respect to these kind of proteins, you may not be really doing justice, and you may actually not be identifying the particular virus, which is your COVID-19 virus. So what do? We therefore look at the possibility of the trimeric spike protein, which is out here. This particular protein helps you to identify some of them. And of course, a lot of the testing is dependent upon the viral RNA. And I'm sure a lot of you would have read about it already in the literature. Now, if we look at the disease per se, what are we able to see with respect to the disease part of it? The disease shows an early infectious stage where the viruses are replicating. All this is happening within the pulmonary system of the patient, and eventually the body tries to fight out the infection, which is your host inflammatory response phase. And it is at those phases that the inflammatory cytokines start coming up and you have the DIC-like picture. A lot of it was discussed by Dr. Nair, and therefore I'll not get into details of that. However, the moment we try to target the PCR part of it, this picture needs to be kept in mind. And in this picture, which is obvious, the RNA starts coming from day 0, and you are able to actually see and this is usually within the symptomatology period, and you're able to pick it up for a pretty long time, till almost 15 days. Now, when you look at the RNA, it's a single-stranded RNA, which is having a 30 kilobytes length. It has got various proportions, which are actually, using their proteinaceous differentiation eventually based on what we have just shown in this picture as well. Now, if you look at the RNA part of it, there are 3 important genes which people look at. One is the RDRP gene, the other one is the E gene and the N gene. And for all of them, fortunately, we have the oligonucleotide primers which are available. They have already been sequenced, and that's why the kits are easily available for us. What one needs to remember, though, is that these genes are not otherwise genes which are not shared between other coronaviruses. So it's about which gene will you take for identifying the virus. So let's look at this particular PCR assay, the RT-PCR assay, which seems to be the most important assay currently, and everybody wants to use it, was originally proposed by Scharte from the Berlin University Institute of Virology. And this was the assay which was actually endorsed by WHO. And at the same time, it was also being concomitantly developed by the CDC as well. There was a concept of screening and confirmatory testing. I know a lot of people would remember that the screening and confirmation part of it is also given in the advisory from the ICMR. And if you look at both of them, this is how the entire thing pans out. So you have an E-gene assay, which is used as a screening tool. And this E-gene assay is primarily used as a screening because it is a gene which is shared by a lot of coronaviruses. On the other hand, you have the RNA-dependent polymerase gene assay, which is a confirmatory assay, and this is what the WHO strategy was, that you start with an E-gene assay. If that turns out to be positive, you do an RNA polymerase gene-based assay for confirmatory testing. Concomitantly, you can add another confirmatory assay using the N-gene assay. Now, this part of it has actually changed a lot with CDC now, where they have directly gone into the confirmation mode, and they have gone directly to the COVID-19. So these are the various targets which you can potentially look at. And I would like your attention on these genes vis-a-vis the number of copies, where you have to understand the limit of blank is to the level of these copies. And this is why it's the important point here is that having it below this level might always become a major challenge. So if we look at the coronavirus, in terms of the assays, when you're trying to see with respect to the real-time PCR assay, with respect to the various sources of sample, what you will observe is that the nasopharyngeal swab samples and the sputum samples correlate very, very well. And eventually, whether you look at the severe and the non-severe patients, the signals are exactly the same, and you're able to actually pick them out very, very clearly. More importantly, the picture G, if you see, is very clearly showing that you have a better outcome from the sputum. So obviously, the samples which are coming from the chest are far superior. Let's look at what other tests can potentially be done. You can look at the antibody against the COVID-19. And this is the premise for this is that you have the antibodies which are going to be produced after you're getting infected with the virus. And this usually happens on day 7. And it continues for about a few more days. So you will have the IgM and the IgG. And this part of it is already known to a lot of us in other viral illnesses as well. Now, what are the ways by which you can identify these antibodies? There are 2 prominent ways by which you can identify them. One is your ELISA-based assays, and the other assays which you can do is immunochromatography. And I'm not really going to get into details of this because I'm aware that most of us have been doing this for other diseases, and these 2 techniques can potentially be used. Let me just try and show you what has come out with some of the studies which have done this. And this picture is actually showing you how the immunochromatographic technique will be giving you the bands, which we are already familiar with when we do malaria antigen testing. This is an actual case scenario here where you're seeing one of the publications which was there, which showed us how different scenarios were there. In the first one, you are able to see both IgG and IgM. In the second one, you're not able to see only a very faint IgM is there. In the third one, there is no IgG, no IgM. Fourth one, you have a very faint IgG, and likewise in the rest of them as well. What is important to know is to see this particular picture in front of you, which is very obviously telling you the titer of these antibodies and how these titers differ in different individuals. So if you look at the titer is pretty high when you're seeing here the strong ones, and the ones which are weak are also there. So you have a responder which is producing a much higher level of antibody, and the ones which are producing relatively lower levels of antibody. And if you look at the levels of antibodies within and the severity, you will observe that the patients who have lower levels of antibody are less severe than the patients who have a higher level of antibody, and that's what has been demonstrated in this. This is also eventually correlating with the viremia. So the viral percentage of viral clearance, if you look at it, the ones which have non-severe patients where the antibody levels were lower, their viral clearance incidentally was better compared to the ones which had a severe disease and their viral clearance was more difficult. And again, if you look at the various various days from the time of illness when the patients had the IgGs, the IgMs, and the RNA positivity, what's pretty obvious is that you start having these antibody only on day 7 of the illness. And as you progress further, the RNA starts getting dwindling on, whereas the antibodies start becoming more prominent. Okay, so what are we left with? We're left with the antigen tests. So antigen tests have a sensitivity which is as low as 34%, to some of them to add as high as 80%. But currently the WHO does not recognize the use of antigen testing for diagnosis of patients with COVID, although they're very clearly saying that it's highly encouraged to keep looking for a possibility of using antigen-based testing. Now, you know that I'm a hematology person and I have an itch of hematology. So I would really want to know how does hematology help us in getting the assay further? So if you look at this particular picture, I am going to talk a little bit about morphology as well as about the flow cytometry. This particular picture very clearly shows you that what I'm able to show you here is that you have a healthy donor and you have these patients, and in all of them what you're able to see is the presence of these monocytes. And what is very striking in all of them is that if you look at flow cytometry, the monocytes which you're seeing in this are the monocytes which have a very high forward scatter, and these monocytes are actually different from the usual monocytes which you find. So that's what has been seen in flow cytometry, and the p-value is very obviously different with a high forward scatter monocytes. And then this is a typical image where you are seeing a flow cytometric image of high forward scatter flow cytometry, and you are able to identify these monocytes very distinctly separately. In fact, some of it was already shown by Dr. Sukesh as well. On the contrary, if you are looking at the forward images which you are seeing on the flow cytometry now, what you're able to see that these high forward scatter images are also available and they can be taken care of along with that. So therefore, for us to actually really do flow cytometry will really help us in the long run. So what we are doing in this next image, what I'm showing you is the markers of expression which are done on flow cytometry. And these are the ones which are, just give me a second. Sorry. So what we are seeing here is the presence of the macrophage markers which are present on these, and they obviously get activated during this particular illness, and we can pick them up on flow cytometry as well. These are the other macrophage markers, and other possible points which one needs to keep in mind is you can also look at the presence of various T lymphocytes and various other lymphoid cells as to how they express. The most important ones being the presence of CD27 and CD38 high expression in these cells, as well as presence of HLA-DR and expression of CD14 and 16 on the monocytes. There is also expression of granzyme A, B, K, and M, and perforin on all these cells, and as you can observe in this particular flow cytometric scatter plot. Now let's look at the counts which are there, and if you see that these pictures are from patients, who are from the cases of COVID pneumonia, non-serious COVID pneumonia. And what you're observing in all of them is that there is distinct lymphocytopenia, something which Dr. Sukesh already showed us. There is definite count low as far as CD3 and 4 positive cells are concerned, CD8 positive cells are concerned. There is hardly any difference in the ratio, though, which needs to be understood very, very clearly. So the ratio does not get affected. So it's not like typical HIV-like illness where you have an alteration in CD4 to CD8 ratio. Again, when you're looking at the mild and the severe forms will obviously have a much worse, proportion of reduction in these cell counts. And important point is that the ratio still does not really get affected to that extent. And as the patients recover, what you're able to observe that the recovery is also giving you recovery in the counts, and they are all coming back in that particular patient. So this is an ROC curve which is showing various cell counts vis-a-vis the sensitivity and specificity of the illness. And it's very obvious what you can see from here, that the regression analysis shows that all of the counts with respect to cytopenias are able to give you some information. Same thing has also been seen in some other publications. Again, I'll not get into details of this, but this is again something seen both in ICU as well as in non-ICU patients with suffering from COVID per se. Now, what are the other tests which can potentially be looked at with respect to the laboratory testing? If you see that you will also be looking at the D-dimers, the neutrophil counts, the creatinines, and the urea. And it is not a rocket science to know that as you are having the survival, if you are surviving, you will have better counts vis-a-vis the ones which are not surviving. So if you see the urea and the creatinine, they're getting deteriorated in patients, who are having this disease, which is very, very significant. And the ones who are recovering are obviously coming back to the baseline. Similarly, if you look at the temporal changes of the laboratory markers in D-dimers, in lymphocyte counts, in IL-6, there was a question as well. In all those cases who are actually getting into a macrophage activation syndrome and having a very severe DIC, it's pretty obvious that all these markers are actually becoming very severe and giving a tough time to the patient as well. So what should be the testing algorithm? How should we go about testing a person if somebody is being suspected of COVID or even to allay somebody's fears? We would like to have a reliable procedure. Which should be pretty simple. You should have a specificity which should be pretty high, and it should be easy to use. Now, when we say all this, it is possible in our usual circumstance. The current circumstances that we are placed in, we are placed in a time of rationing. And therefore, that's where it becomes extremely difficult for us to decide who to test and who not to test. So if we look at the current recommendations in the country, the Indian Council of Medical Research virtually changes their versions almost alternate day basis. And the latest version, which I have been able to lay my hands on, is this one, which says the strategy of the version 4 dated 9th of April is the following. Number one, all symptomatic individuals who have undertaken international travel in the last 14 days, all symptomatic contacts of laboratory confirmed cases, all symptomatic health care workers, all patients with severe acute respiratory illness, which includes fever and cough and or shortness of breath, asymptomatic direct and high-risk contacts of confirmed case should be tested once between day 5 and day 14 coming in her contact. In addition to that, they have also given us recommendations with respect to the hotspot or cluster testing, where they've said that all symptomatic patients who have this upper respiratory like illness, they should be tested within 7 days of illness with RT-PCR, and after 7 days of illness, first the antibody test, and if it is negative, you can do an RT-PCR. As far as the cluster testing is concerned, there is a very interesting the chart which is given with respect to testing, where they're talking about rapid antibody testing and looking at it whether it's positive or negative. And then if there is a possibility of RT-PCR, confirming by RT-PCR. However, if there is no RT-PCR, you will consider it as positive case and then quarantine accordingly. Now, if I look at the testing algorithm per se, for me, as on date, I would prefer the test to be done only in symptomatic patients. And I would prefer a combination of RT-PCR and antibody testing, because that would let me know whether the patient is having and what will be his immune status at some point of time. If I cannot do that, which obviously I cannot, the easiest and the best thing to look at is at least follow what we are following down here. That is, within first 7 days of illness, look at the RT-PCR. And if it's after 7 days of illness, do an antibody test. If negative, then do an RT-PCR. Perhaps that will help us to channelize and have our testing algorithms taken care of. Just to give you a view of how to interpret these tests, if you look at the RT-PCR, IgM and IgG in totality, if you have RT-PCR positivity, the patient may be in window of infection and may be asymptomatic also. If you have RT-PCR positivity with positivity for IgM, this is an early stage of infection. If you have all the three positive, that means the patient is surely infected and has an active phase of infection. If you have RT-PCR positivity and IgG positivity with no IgM, that means he's perhaps in the late stage of infection. If you have only IgM positivity, then it may be an early stage of infection and RT-PCR may be false negative. And this is what needs to be kept in mind. There are about 30% cases where the RT-PCR may be clearly negative and it may be falsely so. If you have only IgG positivity and RT-PCR is clearly negative and there is no IgM, this indicates past infection and obviously the patient has therefore recovered. If you have a patient who has both IgM and IgG positive but no RT-PCR, please keep looking for the RT-PCR and probably taking a better sample, because then the patient might actually be having a false negative test. So with that, I come to my take-home message. My take-home message today is stay home, stay calm. That is the most important point which one needs to take from my presentation today. What are the tests that need to be done? We need to follow the ICMR guidelines, and the currently tests which are available are the RT-PCR tests, and antibody tests are likely to come in soon. Please keep updated regarding the directives from the government, and the best that you can do is look at the ICMR website on a regular basis. They keep changing it, usually in the evenings every day. And as Robert Plant in his song has said, even this shall pass away. With that, take care and be safe. Thank you for your kind attention, and should there be questions, I'll be happy to answer.
Thank you, Dr. Handu, for a very informative sessions. Sir, we have many questions here. Okay. So the question is, this is on the blood transfusion. So is the blood transfusion in quarantine period good or bad?
So the point is, there are specific guidelines to this from what is called National Blood Transfusion Council of India, which in fact have already been in circulation. What is clearly mentioned is, if there is somebody who is suspected of being COVID, even if he may be asymptomatic, the person needs to be deferred for at least 28 days. This is what has been given in that particular guideline. And probably that will be the best thing to do at this point of time. Though there is no evidence to suggest that this particular virus gets transmitted through transfusions. There is one or two publications which are available in the literature which talk about 15% cases having circulating RNA in the blood. However, that's not been replicated by others so far.
Sir, there's a question. Who recommends to prioritize testing for COVID-19? Do you think that all healthcare workers should be tested to reduce nosocomial infection?
Well, this is a very interesting question and at a tough time, because if you look at the current circumstances, we have limitations of kits. We have directives which have to be followed from the government and the Honorable Supreme Court. And at the same time, we also are expected to provide healthcare to the patients on the front. Now, there have been cases in the recent past where patients were not symptomatic and eventually they were found to be COVID positive, only ensuring that the healthcare workers who were providing healthcare at that particular point have all been quarantined. So if I am asked at a personal level, well, I would prefer all the healthcare workers to be tested. There is also an algorithm to this effect which has come from the ICMR just of late, and perhaps it's just a matter of a time, maybe a day or two, when perhaps it will be allowed that all the people who are actually actively involved in healthcare, symptomatic or asymptomatic, might be allowed to be tested.
Okay. So, any chance of infection if we are dealing with blood or plasma of COVID-19 patient? This is from Dr. Varun Raj.
So, as far as the blood and the blood products from a COVID positive patient are concerned, they have to be considered to be COVID positive unless proven otherwise. There is enough literature to suggest that there is no COVID transmission through blood. But we must remember that the blood is anyways taken in the tubes, and the tubes are being handled by human beings, and the human beings have a potential of transmitting infection through fomites. So please take adequate precaution. You do not need to get worried about handling these samples. These samples can be handled by usual precautions which you take in the laboratory. We are dealing with diseases like HCV and other diseases which are primarily transmitted through blood. When we can take care of them, I'm sure this is just a simpler way of looking at it.
So one last question, sir, which has been asked is that regarding this pooled testing for PCR, the pooled PCR testing. So what are your views on that?
So at a personal level, if you ask me, I am not really for pool testing in this kind of a circumstance, because again, the pooling will depend upon how pooling is done. So if the pooling is done by taking the swab and then putting it in a single viral VTM, perhaps it may still work. But if you're going to take all the swabs in different VTMs and then you're going to take those VTMs and mix them up and then create it, the sensitivity, as far as what we have seen from the literature in the other cases, drops down significantly. But this is my personal view. Scientifically, there is evidence to suggest that this can be done potentially, and I'm sure the government will probably look into it and ask people to see whether this can be done or not done. Just look at the ICMR website, and next 2-3 days, hopefully something else will come up on this front as well.
Thank you, Dr. Handu, for the information. And I request Dr. Sujay Prasad to share his screen, please. Dr. Sujay Prasad?
May I please request everybody to keep their lines on mute, please. Hello. All lines on mute, please. Till that time, we can have more questions, ma'am. By the time we are getting Dr. Sujay Prasad online. Oh, sir is online. Okay.
Hello, I'm Dr. Sampada. I have got a question. I'm Dr. Sampada. I have got a question. Hello.
We can hear you, Dr. Sampada. Yes, ma'am, we can hear you. I would request to.
Yes, I would like to ask one question, if you don't mind.
Ma'am, can we just wait for Dr. Sukesh to finish? Hello.
Hello.
May I please request
Can
you?
I ask a question?
Ma'am, can we just place your question till Dr. Sujay is starting to present, ma'am? So can we have the question after that?
Yes, afterwards.
Yes, thank you.
Okay, thank you.
Please unmute.
Yes, yes, yes. All this.
ಹಲೋ ಏನಾಯ್ತು ಹಂಗ ಮಾತ್ರ
Can we all please
ಕಾಲ್ ಅಲ್ಲಿ ಇದೀನಿ.
Hello. We are trying to hear Dr. Sukesh Sujay. Please mute your lines, please, everybody.
Can you hear me?
Yes, sir, we can hear you.
Can you see the?
Yes, so you can see the screen as well.
Okay.
Please go on.
Role of laboratory in COVID-19 pandemic. I think it's central in diagnosis and prognosis of COVID-19. It plays an important role in confirmation of presence of SARS-CoV-2. Then there's a role to play in understanding what.
So much of noise.
There's so much of noise.
Can I request the organizers to?
We have muted the line. Dr.
Can you hear me?
Yes, sir, we can hear you.
Okay.
Please go
And
on
the screen. And I think there are many more people talking. Anyway, so I'll just go through this. I think I've done it twice. What is important is I think the laboratory has a huge role to play in this pandemic and quite central in the theme. In recent times, the coronavirus outbreaks have been in the year 2002, it's been SARS, followed by MERS, and then now it's COVID-19. And you see between SARS and MERS, it was 10 years, and between MERS and COVID, it's 7 years. So I don't know whether to read too much into that. Currently, the mortality data of MERS-CoV is the highest at 34%, SARS is at 10%, and currently COVID-19 is at 2 to 4%. Looking at, and that keeps coming on a daily basis in our newspapers. Incidentally, what happened was on 31st of March, we received a circular from Government of Karnataka that we, being a lab approved for testing COVID-19 samples, had also to be doing fever clinics. So fever clinic is essentially a role of a hospital, but in these times, they expect the testing labs to double up as fever clinics as well. And they have a nice algorithm to indicate when a patient with, they would do a triage using the ICMR criteria. And then if it is a suspected COVID-19 with high risk and moderate to severe symptoms, they would go straight to the COVID hospital. And if it's mild or moderate, then they would get into a swab collection center. The swab would be collected and then sent across to the testing center. While the reports are awaited, the patients are taken to hotels designated as quarantine centers. And once the lab results come, if it is negative, they would be advised home quarantine. And if it is positive, in mild cases, a supervised isolation center, and in a severe case, a designated COVID hospital. Now, this is the workflow that the government of Karnataka laid out for us. And that's where we decided that we had to document our processes, and the activities involved in COVID-19 testing would include a fever clinic, a flu corner. We are currently not taking on this role. We are, in fact, developing infrastructure and processes to double up as a fever clinic. We have not started sample collection in our lab. However, we are trying to look at using the drive-through collection and then go ahead and have a dedicated collection booth. And finally, of course, we have been testing over the last 2 weeks. Now, when you look at each of these activities, the fever clinic basically receives patients with complaints of typical flu. And then the fever clinic has to take details of demographics, travel history, COVID contact, and congregation, if at all there is one. And then go on to do a clinical examination, which includes temperature, weight, BP, chest examination, and oxygen saturation with a pulse oximeter. And then triage to see if the person needs a collection to be done or not. All along, we have to ensure safety of staff and patients. Now, if a patient deserves to be tested, then a sample collection has to be done. And this requires that there is safety of patients. Staff have to be ensured that they are safe. A sample collection should be done. And typically, its current recommendation is that it's nasopharyngeal swab. We can take an oropharyngeal swab in symptomatic cases. We ensure that there is disinfection of area surrounding the patient and ensure proper disinfection of the outer surface of the sample container, because that's a surface contact with the patient and probably the virus. Of course, when it comes to testing, we have to ensure safe transportation of samples to the testing area, accessioning, opening and managing of the viral transport medium, biosafety cabinet, RNA extraction, master mix preparation, amplification, quality control, reporting as per the criteria, ensure proper communication to patient, hospital, and the government, and finally, and not the least, biomedical waste management. Now, the government of Karnataka shared their standard operating procedures for flu corner or a fever clinic with us, and reasonably good to see how they have laid out the administrative planning, the timings of the clinic, what staff should be there, who are the personnel who should be involved, what is the engineering requirements, and interesting to see that the waiting area should be well ventilated, natural ventilation, exhaust fans should be used, avoid ceiling fans and air conditioning. Of course, social distancing and hand sanitization and mask is essential. The healthcare workers need to have personal protective equipment to ensure that they are covered and there's no exposed area which can get contaminated. Disinfection of the flu corner is very essential, hand hygiene, and of course, patient movement protocols. So with that SOP, Dr. Ajit, my colleague in radiology and clinical imaging, came up with this workflow where he had one coordinator taking care of all the patients who walk into our lab to do the triage. They would, as they enter, they would we would insist that the patients have hand hygiene either through soap and water or hand sanitization, check their temperature, and provide a mask if they're not having one. And following this, the person would decide whether that person gets into the fever clinic or gets into a routine test area. Now, those who come for the fever clinic would be in a waiting lounge where demographic details, contact numbers, address, photograph, and ID proof would be taken. And then a nursing station where temperature, weight, BP, and oxygen saturation would be collected. This would lead to the physician who would check and depending on the ICMR criteria for COVID-19, decide whether the sample needs to be collected or he or she needs to go for other tests and not necessarily COVID testing. Now, when they refer to COVID testing, the collection happens and they are sent to an isolation area. Only if the test is negative, they are sent back home and asked to quarantine themselves. If the test is positive, they are taken to an isolation hotel or a hospital. So much for the fever clinic or the flu corner. From there, I move on to the sample collection, which I believe is very critical, particularly if you have to get good results from the molecular testing. Currently, we are looking at two possibilities: the drive-through sample collection facility or a dedicated sample collection area, which includes a biosafety booth with negative pressure, virus burnout, and a BSL-3 practice. This is the current drive-through which we use for other tests. We are not doing it currently, but we intend to convert this facility into a drive-through swab collection. And this will happen over the next 5 days to 7 days. The other design which we are coming through is a biosafety booth, which is nearly hermetically sealed. It will have a negative pressure. It will have a BSL-3 practice. Disinfection is easy because it's a booth which is 4 by 6 by 7 feet in height, and it ensures safety of patient and the staff. There are many booths that have been going around in the newspapers, and I'm sure many of you have seen this. But my concern is that this can lead to more risk than anything else. If you see, this is a booth which is indoor, and inside is the healthcare worker who is taking a swab. Ideally, if this person is asymptomatic, the only swab he should be collecting is a nasopharyngeal swab and not an oropharyngeal swab. But in this case, it's an oropharyngeal swab. The other concern is that the person who is outside is liable to contaminate people who are standing around him. So the recommendation is, if there are outdoor booths, the healthcare professional is inside the booth with an air conditioning and a positive pressure. The patient is outside the booth with ventilation, well ventilated. And of course, social distancing has to be maintained even though it's outside the booth and outdoor. The booth has a positive pressure. Because the healthcare worker is inside the booth, and the air movement should be from inside the booth to the outside, so that when the patient is standing outside, his aerosols do not enter the booth. And finally, the disinfection is that of the booth from the outside. If there are indoor booths, then the healthcare professional is outside the booth, the patient is inside the booth. There's negative pressure inside the booth to ensure that all the air that is inside the booth is sucked out and it goes through a virus burnout and ensures it is safe. And disinfecting the booth is from the inside after every patient. Now, the diagnostic respiratory specimen, it's very important because that is the primary specimen for COVID-19 testing. While we are considering this, it's important to look at the healthcare professional in the room should wear N95 mask. There should be eye protection, gloves, and a gown. The number of healthcare professionals should be at the minimum. Visitors should not be present for sample collection. Specimen collection should be performed in a normal examination room with the door closed. Now, this is where we are considering the biosafety booth, because if there's a normal examination room, the possibility of contamination is very high. And the next point, which is cleaning and disinfecting the room, can become extremely challenging. So when you look at the CDC website for specimen type and priority, it's very important to look at the nasopharyngeal swab for testing asymptomatic persons in a healthcare setting, including long-term care facilities. Because at this time, anterior nares and mid-terminate specimen collection are only appropriate for symptomatic patients, and both nares should be swabbed. Now, it's also important to look at the recommendation for collecting and testing an upper respiratory tract specimen. Nasopharyngeal specimen is the preferred choice for swab-based SARS-CoV-2 testing. When collection of nasopharyngeal swab is not possible, then the following are acceptable alternatives, and that is oropharyngeal swab, the nasal mid-turbinate swab, and the anterior nase swab. Now, additionally, it's important for patients who develop a productive cough, sputum should be collected and tested for SARS-CoV-2. I think this, Dr. Anil Handu also brought it out pretty well, where sputum is a better sample type if the patient is having a productive cough. The induction of sputum is not recommended because that's going to generate a lot of aerosols. So typically lower respiratory tract specimen and upper respiratory tract specimen. For lower respiratory tract, it could be bronchoalveolar lavage or a tracheal aspirate and a sputum. Now, both of them are typically in symptomatic patients who are probably admitted in the hospital. Upper respiratory tract, nasopharyngeal swab or an oropharyngeal swab. And we should be using only the synthetic fiber swabs with plastic shaft, because calcium alginate swabs or swabs with wooden shafts contain substance that inactivate viruses and inhibit PCR testing. In general, CDC is now recommending collecting only nasopharyngeal swab. If both swabs are used, NP and OP specimens should be combined at collection into a single vial to improve the sensitivity. Now, oropharyngeal swab should be taken from the posterior pharynx, avoiding the tongue. I have seen very often oropharyngeal swabs, the swab itself, it's an effort to reach the posterior pharynx. It generally touches the soft palate or the tongue, and it prevents the right sample being taken. Now, JAMA, Journal of American Medical Association, has taken out a nice frequency chart which indicates the percentage of positivity from specimen types. Of course, BAL is the best at 93%. Sputum is at 72%. Now, the concern with sputum is that it's possible only in symptomatic patients with productive cough, risk of aerosols when giving the sample, and so we need to ensure safety of people around the person who's giving the sample as well as the healthcare worker. However, often, instead of coughing it out from the deep chest, saliva is submitted, and then that defeats the purpose entirely. But interestingly, you will see that the nasal swab, the nasopharyngeal swab, also is at 63%. So the oropharyngeal swab is at 32%. So you see the nasal swab will detect only 2/3 of the cases, and the oropharyngeal swabs will detect only 1/3 of the cases. So we need to be aware of this while we consider the sample type for COVID-19 testing. So while we are getting into this nasopharyngeal swab testing, we have seen different ways in which a nasopharyngeal swab is being taken. And that is quite a concern, because typically the swab has to go along the floor of the nose or parallel to the palate and not in any other direction towards the eye or towards the nose bridge. And this is seen better in this cartoon, where the patient's head is inclined to 70 degrees and the swab needs to reach the nasopharynx. It should be in the direction of the external meatus of the ear. And the length of the swab should be such that it almost touches or reaches the outside of the ear. In recent times, there have been paper articles on false negativities in the testing, which is making anti-COVID fight a bigger challenge. And up to 30%, like Dr. Anil Handu mentioned, has been seen in Wuhan. And there are many reasons for this. And I think, in my view, the most important reason is improper collection of sample. Very often we are seeing samples being taken from oropharynx, from asymptomatic people as well who are in the quarantine. It's also about the incubation period of the disease. It's best taken 5 to 7 days after infection, though virus shedding starts from day 2. But it's really difficult to know when a person was infected and how do we identify the 5th day. Transportation of the viral transport medium should be at 2 to 8 degrees for a maximum of 72 hours. If it is going to take longer than 72 hours, it should be at -20. Analytical false negativity due to faulty probes and primers are less likely, but I would put improper collection of sample as the biggest reason. Coming to the testing laboratory, I think Dr. Anil Handu has taken us through very well on various aspects of molecular as well as antigen antibody based analysis. But I've just put up a order from Principal Secretary of Government Health and Family Welfare in Karnataka on RT-PCR as well as rapid antibody based blood tests. Now, from the video conferencing with Dr. Neeraj Agarwal the other day, it was made clear that ICMR does not allow private labs to use serological based methods for COVID-19 disease. So we are not into serological tests as of now. We are only doing RT-PCR. This is a good chart modified from Lippi et al. And it shows how RT-PCR and antibodies play a role in laboratory diagnostics. Now, when you look at the epidemiological surveillance, both RT-PCR as well as the antibodies play a big role, both before and after getting the infection and population-based. But when you look at diagnosis and subsequent monitoring of overt disease, you do not see antibodies playing a role at all. It would be RT-PCR all along. So the reference technique as of now for SARS-CoV-2 is using the real-time reverse transcription polymerase chain reaction. And while it is the gold standard, and Dr. Anil Handu has taken us through all of it, just to reiterate that E gene is the first line screening gene, and it's not specific to SARS-CoV-2. However, RDRP, N, and OF1AB are additional confirmatory genes that different countries use in different combination. This table gives a summary. China, Germany, Hong Kong, Japan, Thailand, US, and France use different gene targets, and all of them are acceptable by their own governments. Similarly, ICMR has put up its own acceptance, and all of these are definitely acceptable. Of course, the screening gene is the E. If that is negative, the lab is not expected to do anything further. But if E gene is positive, then RDRP, ORF1AB, and N or N needs to be tested. Of course, this is giving the same information. There's a very nice article in Clinical Chemistry indicating the molecular diagnosis in an outbreak of pneumonia. And what they did was they took 2 patients who had ORF1B and N gene in the sample, and they proceeded with diluting the RNA after it has been extracted. When you look at the patient number 1, it has been tested on neat, 10 times dilution, 100 times, 1,000, and 10,000 times. And there's a difference in the way ORF1B and N gene have behaved. You would appreciate that the N gene is detectable even at 100 times dilution, while the ORF1B is negative. It's even more evident in patient 2, where the N gene is positive even at 10,000 times dilution. So they go on to say that the results demonstrated the clinical value of these respiratory samples for molecular detection of 2019 nCoV. In addition, the N gene RT-PCR assay was found to be more sensitive in detecting 2019 nCoV RNA in the studied clinical samples. It is possible that these clinical samples might contain infected cells expressing subgenomic mRNA, resulting in more N gene copies in the sample. So that's the reason why N is more sensitive. Now, once a patient is COVID-19 positive and he's admitted, either symptomatic, asymptomatic, he's admitted to the hospital and he starts becoming symptomatic or worsening, there are a set of laboratory investigation that would definitely help. And CBC has been very elegantly described by both Dr. Sukesh sir and Dr. Anil Handu. But there are other tests in chemistry, including the albumin, lactate dehydrogenase, alanine aminotransferase, aspartate aminotransferase, bilirubin, creatinine, cardiac trope-I. HS trope-I is a marker that is being used to monitor COVID-19 patients. D-dimer, prothrombin time, procalcitonin, C-reactive protein, ferritin, and IL-6. IL-6 has been discussed, of course, but it's also an indicator for the cytokine storm syndrome, which is being seen in very severe cases of COVID-19 disease. And just showing you a screen, meaning images of our lab. This is the area where we receive samples. The sample receiving area has a place where the accessioning is verified. The samples are then taken into the sample extraction, where we have a biosafety cabinet and a extraction automation. That's a biosafety cabinet class 2A, and another one which is a backup in an adjacent room. This is the reagent preparation room, which has a laminar flow, a -20 and a 2 to 8 degrees, and a PCR cabinet for mixing, adding the template, and a pass box where the extracted RNA is transferred. And finally, the amplification room where the cyclers are present. This is basically antibody test, and I think Dr. Anil Handu has mentioned this. I'm not going to go into details. Coming to the safety issues, I think it's very important while we are in the lab that we ensure complete protection to our healthcare workers, particularly those working in the molecular lab. They are exposed to the samples that come into the lab as well as the RNA. So it's important that they are in PPE along with N95 mask. Now, CDC has come up with an acceptable alternative to PPE, which is a face mask. Of course, it should not be the face mask alone. It should be along with other gowns, goggles, and the shoe cover. For the general population, papers are carrying such news items. You can't step out without mask in the city. And these masks, while people try to wear N95 masks, it is to be discouraged because N95 masks should be preserved or conserved for the purpose of healthcare workers. And a simple homemade cloth-based mask can be used by the general population. This is a nice table which recommends the use of PPE based on various scenarios for medical field staff. And they have listed it on the risk level. So if we are entering an isolation ward or an ICU where COVID-19 patients are being treated, I think surgical mask, glove, shoe cover, goggles, hazmat suit, and N95 are all necessary. And so is it necessary for labs testing COVID-19 sample. However, labs that do not test COVID-19 samples, what the recommendation is, it's a surgical mask and gloves. And this is necessary for all departments that are handling samples, which we believe is not COVID-19, but like Dr. Anil Handu mentioned, every sample needs to be considered positive and handled appropriately. So we don't need to have a full body suit to handle a CBC sample. However, a proper maintenance of hand hygiene, glove, and mask is sufficient. The hand hygiene, why, how, and when is very well illustrated by WHO. And the important thing is hand hygiene is therefore the most important measure to avoid the transmission of harmful germs and prevent healthcare associated infections. So it's very important that we comply with hand hygiene while we are in our healthcare settings. It's also, they have put up a pyramid which shows where sterile gloves are indicated, where examination gloves are indicated, and where gloves are not indicated. Incidentally, when you look at where gloves are not indicated, where direct patient care, taking blood pressure, temperature and pulse, performing subcutaneous and intramuscular injections are all apparently not indicated. The CDC also has provided a preparation of viral transport medium SOP, which is very interesting because when large numbers of swabs start coming in, it's important that we try to conserve the resource and start preparing these medium ourselves. There's also a nice website where NEJM Knowledge and AACC Learning Lab have provided tutorials where one could take for about 10 to 15 minutes, and you would get a certificate of completion on the topic of coronavirus disease 2019. So essentially, we need to practice abundant caution. We have to ensure social distancing within our own labs. All departments need to be isolated within their own areas. Earlier, while biochemistry department staff would come to hematology would go to molecular, there would be a lot of cross-departmental discussions, meetings. I think all that has stopped in our lab. Canteen has been closed, except that the food is prepared and food is handed only to one person from each department, who then distributes it to all the other staff. Hand hygiene is extremely important. Soap and water, frequently hand sanitizer with 70% IPA should be made available in abundance. Mask, particularly N95 for specific departments within the lab like molecular microbiology, where body fluids are handled. Surgical mask in the absence of N95, very important at the minimum. Cloth mask is not recommended for healthcare workers in these departments. However, front office staff and other staff can wear cloth mask, provided they are maintained well and disinfected on a regular basis. Temperature monitoring of all who enter the building is being practiced, and we need to ensure this so that we at least identify patients who need to be attended to. Now, as we go along in this, we will come across our own staff becoming symptomatic. It's very important to identify them. So we have regular checkups for our staff who go to our physician, Dr. Ajit, and then get themselves examined on a regular basis. We identify the person who needs to be triaged, test them for internal purpose, isolate them, monitor and treat if at all. So to summarize, lab has a significant role to play in COVID-19 pandemic. Safety of healthcare worker is paramount. Fever clinic will triage cases to enable selection of case for testing. Sample collection in asymptomatic and symptomatic cases is very important. How we approach this, particularly nasopharyngeal swab. Testing strategy and protocols need to be understood for better reporting. Lab needs to be updated on constantly evolving strategies for selection of cases, sample collection, and testing protocol. Thank you very much.
Thank you, Dr. Sujay, for a step-by-step explanation of the entire protocol. And I request all the three speakers to unmute their mic and also, if possible, the video. We do have certain questions for all of you. So Dr. Sujay, there's one question that how long is the patient infective and up to which phase?
Oh, that's an interesting question. I think that it becomes evident with Dr. Anil Handu's graph, where he shows how the virus actually progresses, increases in shedding and subsides. I think anywhere from 2 days after infection to, I think, about 21 days is when the virus can be recovered from the nasopharyngeal swab. But the best time to actually do a throat swab is anywhere after the 4th day, right up to the 14th day.
Okay. So there is a question from Dr. Sushrut for Dr. Sujay Prasad. What sample has better chance of picking up the virus, the nasopharyngeal or BAL?
The BAL is evidently the most recommended specimen because that's where I think the virus is causing the damage. And it picks up 93% of cases, whereas nasopharyngeal swab picks up only about 63% of cases. The importance of nasopharyngeal swab comes in asymptomatic and mild symptomatic cases, because in such cases, you cannot do a bronchoalveolar lavage. It's an invasive procedure and best avoided.
There's a question from Dr. Amrita for Dr. Sukesh sir. Just wondering if any Indian study so far has covered enough patients to reach to a conclusion in terms of difference in disease pattern in India.
So, yeah, I think ICMR is inviting a lot of proposals for studies. And yes, I have also been roped in through our infectious disease department because I will be doing the cell population data part, but nothing worth publishing at this stage.
Sir, there's one more question for you. This is from a clinician, Dr. Kishore Kumar. Convalescent plasma therapy, as we are talking about the plasma therapy, are tests to quantify titer of antibodies in plasma available. I am a clinician interested in starting a CP therapy once ICMR gives nod. Please share your input on this.
Yeah, so the convalescent plasma therapy is a proposal. I think Trivandrum Suchitra Tirunal has initiated it. For example, we had 2 patients, one is recovered, but unfortunately he's still positive by the molecular method, the RNA method. To be so obviously he still will not be qualifying to donate convalescent plasma. Only if he's negative for the virus will he be, and of course the antibody kits are coming up, and they should be possible to measure the titers in the convalescent plasma, but provided the patient is negative for the virus. The plasma, the article that we published along with Dr. Eban, the gastro department, the hepatology department, was plasma exchange, low volume plasma exchange. But that's mostly focusing on severe illness, which goes into the macrophage activating syndrome.
Okay. So there's a question from Dr. Handu. Will flow cytometry help in early diagnosis and monitoring?
So yes, so if you look at it from that standpoint, I had shown some papers already in which I had very clearly shown that there is a significant population of these cells which are nothing but macrophages taken up on the flow cytometry, having a very distinct forward scatter. If we are going to follow those studies, it's very obvious that whenever you are able to figure that population out, and if they are also showing concomitant activity markers, you will be able to look at the patient with suspicion of possibly a COVID. Eventually, when you follow these patients up, the number of these cells go down significantly. And also at the same time, you are able to see the activation markers also going down significantly. So that eventually gives you a possibility of following them up and also getting an idea of how to go about, in some of these cases, go ahead and do the testing for COVID, especially in the time when you're trying to ration your tests. Having said all this, it is not a diagnostic test per se, number one, and it has only a role to play in a follow-up of the patients. At least that is how it is currently. There is also a lot of work going on parallelly between people where they are trying to see whether all these tests together can develop some kind of a score or an algorithm which can predict the possibility of finding out patients who are suspected in upper respiratory tract illnesses that they might actually be COVID. But it's still not come to that extent that people can just depend on it reliably. So as of now, RT-PCR is the gold standard. We all need to accept that. Number one, antibody testing together with RT-PCR is a better modality. Number two, and obviously, if we are able to get these ancillary techniques into the picture as well, who knows? Maybe we'll be able to get better information.
Okay. Dr. Sujay, there's a question from Dr. Jayesh Trivedi. He's asking if anyone knows the IgG titer ELISA or CLIA kits approved by ICMR for passive immunization.
I think there has been a blanket statement by Dr. Neeraj Agarwal about serological methods by private labs. And I think it was made amply clear that private labs will not test serological methods as of now. That may change as we go along, but at this point in time, this is the information I have. But obviously, for the understanding of vaccination status as well as past infection, the role of IgG and IgM, both for epidemiological purpose and herd immunity, will take importance.
Okay. So there is a question again. This is a question from Dr. Surgeon to Dr. Sujay Prasad. He's asking, if a laboratory person comes in contact with a positive case, are there any criteria of quarantine for other laboratory staff members, and any experience with my lab kit?
Okay, I think there are two questions here. The second question is my lab kit.
Yes, sir.
Or is okay.
Yes, sir.
The first question is a good one because we went through this process of trying to understand. We have a 60,000 square feet facility where 200 people work. So the concern was, even if one person falls sick, do we shut down the entire building? So that's where we started looking at models from Singapore and other countries in Asia, where information came that within the building, people are advised and recommended to stay within their departments without moving between departments. So even if one person falls sick in a particular department, only that department shuts down and not the entire building. So we immediately put a policy and we put across a statement to all our staff who are in the building to maintain social distancing, isolate themselves into specific departments without interdepartmental meetings. If at all there is, it should be on video, and avoid reaching the canteen. Now, canteen is open only for preparation of food, and food is transported to the departments. Each of the department, though NABL does not recommend food being eaten in department, I think these are unprecedented times, and we have made designated areas within the department where food is being taken and had. In addition, what we have done is, because the workload has come down to 20% of what we had, we have scaled down our working force to ensure that there are backup teams at home. The teams at home are told very clearly it's not holiday, it's a backup team that they have to prepare in the event, even in the eventuality where the current staff falls sick. So I think that is very important for us to follow. Otherwise, it's going to be extremely difficult to shut down. What happened in one of the hospitals in Bombay is testimony to that. Now, coming to the MyLab kit, in fact, we started with the MyLab kit, and I think it worked well. We had initial validation followed by some testing, and it worked well. We had no concerns on the MyLab kit.
So there are two questions for Dr. Sukesh. There's one from Dr. Nishit Gupta. So he's asking, any role of HFLC parameter in screening while seeing CBC?
At this moment, no. In fact, if you look at most of the, right now, the most parameter which is identified is, unique parameter which is identified is monocyte Z, which Dr. Anil had shown it on the flow cytometer. Monocyte Z is actually the forward scattered data on monocytes, which of course is increased in patients. But again, they are increased because there is changes that Dr. Anil reflected, but the increase is mostly towards getting worsening scenarios rather than diagnostic. So it's mostly a prognostic tool. The HFLC, of course, is definitely not the other way as you can use in viral infections like dengue. So we'll have to see, because the number of cases have to be seen, especially in centers which use hemocytomorphometry, which I think are plenty in India compared to other countries. So maybe something will be identified over a period of time. It has to be either centers in Delhi, Bangalore, where there are more patients. In Vellore, there are hardly any patients. And you must realize that most of the cell counter data should be obtained on samples which should be processed within 4 hours of sample collection.
So there's a question from Dr. Reshma Nambiar. She's asking, effectively, how many samples should be negative to clear a suspect case of COVID-19 as a negative? So how many samples
this
need
is
to
a
be...
question for?
So you can answer, or maybe Dr. Handu can answer.
I think Anil can answer.
Yeah.
So the question is, if I'm suspecting, first of all, if you're dealing with somebody who's asymptomatic, at least at this point of time, I think we should just leave him alone. However, if you're feeling that there is some kind of a possibility that the person might have developed an infection, so in such a circumstance, as per the ICMR guidelines, the current status is pretty clear. We need to take a sample of RT-PCR and we need to go ahead for testing. The important point with Dr. Sujay also very clearly mentioned in his presentation was appropriate sampling. So as long as we are making sure that the sampling has been done correctly and has been taken appropriately from the nasopharynx and that particular test is negative, the patient is considered for all practical purposes negative for the COVID virus. However, for their own safety, it is preferable such people should be quarantined for 14 days within their own confines in their own homes. And post that 14 days, if he still wants to figure out and he's not symptomatic at all, we will, for all practical purposes, consider this person as not having the infection. However, if a patient has had a test which was negative and eventually the patient started developing symptoms, I would surely want to repeat this patient's test on day 5 and then beyond day 5 and see whether we are able to get this possibility or not. The bottom line still lies in one fact: we have to take the sample appropriately. If we are not taking sample appropriately, the possibility of false negativity is very, very, very high, and that's almost about 33% in one of the studies which has come about. So not a clear answer to this, but as I had mentioned in my presentation, if it was given to me, I would prefer to do the RT-PCR with the antibody testing, and I would prefer to do it 3 times, one on day 0, one on day 7, and one on day 14. And then interpret the test the way I have mentioned in one of the interpretation slides which I had mentioned there. Having said that, this is not the one which is approved by government, so please follow the ICMR guidelines. Don't take my word for it. I'm nobody in this whole scenario at this point of time.
There's a question for Dr. Sujay Prasad. Should we transport COVID suspected sample through pneumatic chute system?
I think it is very clear that COVID-19 samples need to be handled discreetly. There is no, I don't know whether there have been studies on whether it can be transmitted through the pneumatic tube, but I personally recommend not to transport it through pneumatic tube, because it is possible that the tube can open up and there is an aerosol or a contamination of the tube. So please avoid transporting COVID-19's VTMs through the pneumatic tube. Please hand carry it either in the lift or through the stairs.
So there's one more question for you, Dr. Sujay, from Dr. Tushar Toprani. So he's asking your view on self-collection of swab during mass surveillance.
Incidentally, this is a good question. So I was trying to understand how the patient experiences the nasal swab. So what I did was I went ahead and did the self-swab for myself. And it was interesting to see the experience, because first and foremost, I had to select the right swab. And the swabs that were in front of me were cotton swabs. There were Dacron mesh swabs, which was thick, and there were Dacron mesh swab, which was thin. Now, there's no way a thick Dacron mesh swab is used for nasopharyngeal swabbing. It is the thin, flexible Dacron mesh swab that is used for nasopharyngeal swabbing. And though I was able to do it with less discomfort, my colleagues have been telling me that it's not appropriate that we tell our patients to do the self-swabbing, because the swab has to go deep into the nasal cavity, straight towards the throat. And for me, the experience was initially, it was a bit ticklish, but as I went deeper and I hit the nasopharynx, I could hear in my ears a rub. So it was a peculiar experience, because that's when the Dacron mesh actually bent and started going parallel to the nasopharynx, and I had to twist it to collect the sample. So with all of these, I don't think it's appropriate that we recommend self-swabbing by the patients. It may not be appropriate.
Sir, we do have few more questions. So if you're okay, shall I continue asking?
I'm okay.
There is one question that was asked in the beginning. It's about a lot of issue about hemoglobin, because they have been mentioning about the virus dislodging the, playing around with the heme, and that could be the cause for the effect of the lot of respiratory issues. So thing is, yes, if you look at it, we don't have to look at the virus pathogenesis, or we can actually look at the fact that okay, if there is going to be such an issue, there will be intense hypoxia, and obviously the hypoxia can result in increase in erythropoietin. So far, there is no publication which talks about erythropoietin levels in patients with COVID. Probably that's something that may be coming up. So if the erythropoietin levels are higher, that could indicate that the proposed pathogenesis is actually true. The other thing could reflect in the form of increased hemoglobin. But the problem is we also see increased hemoglobin in dengue because of not related to any erythropoietin or erythropoiesis issue, but because of less water content. So that the level of hemoglobin may not be useful. Maybe the RDW could indirectly reflect this particular issue that we're talking about, but I think erythropoietin levels can be looked at.
So there's one more question for you from Dr. Chandana, Dr. Sukesh sir. What surrogate markers you would recommend, hematology or biochemistry, at onset when PCR negative individuals still it can be a false negative?
Obviously, when we showed some parameters, these are parameters which are prognostic parameters, both in chemistry as well as hematology. I think if you're going to monitor some of those parameters, maybe you have to look at the cost factor. And I think I would generally look at cell counter data, because that would look at even recovery also. As compared to biochemistry, but I'm a hematologist, so I may be biased.
May I?
Yes, sir.
So what has happened is false negatives with a clinical suspicion. People have looked at CT scan and proceeded based on CT scan findings. I have not come across laboratory findings being used as individual parameters or as combined multi-parametric approach to look at negative RT-PCR clinically suspected cases. They seem to be going the radiology way rather than the lab for such cases.
Dr. Hando, there's a question for you from Dr. Nilkan Poddar. He's asking any strategy of hydroxychloroquine to lab staff.
Yeah, I can only tell you the strategy which has been given across by the ICMR, and the same stands adopted in our hospital as well. Incidentally, I have also taken hydroxychloroquine. What we need to keep in mind is that for all the healthcare workers, what is expected is that you would have gotten your baseline electrocardiogram done. This is the practice which is being followed in our hospital. And post that, you need to get physically examined by a physician in our system. Once he has approved the fact that your baseline cardiac issues are not there, they then give you the medicine is given by the hospital to us. And in fact, I have also received the entire course for myself. We had to take a loading dose of 400 milligrams twice a day for the first time, and then eventually every week 400 milligrams, which I'm supposed to continue for 7 weeks. We have also been given an advisory to go ahead and even give our contacts, which are at home, my family, except the children who are less than 15 years of age, in whom again they're expected to give similar kind of a dosage. However, the duration is going to be only 3 weeks. So I have not followed that part of it in my family, though. As far as I'm concerned, I have taken already the hydroxychloroquine. I don't know whether I'm immune, not immune, whether it helps me or not helps me, but with whatever literature is available, it seems to be doing a little bit. So, so far, it's not going to trouble you. I think it's an okay thing to do.
So there's a last question now for Dr. Sujay. What precautions should we take in case we have to centrifuge a COVID patient's sample, say for PT or APTT test?
Centrifugation. Interesting question. So I think it's only because now COVID has exposed itself that these questions will start coming up. There is no doubt in my mind that at this point in time, there's no point segregating COVID-only samples and using a separate centrifuge for it. What is important is that to maintain the centrifuge adequately, it has to have its preventive maintenance. The balance is very important. When we put in the tubes into the centrifuge, maintaining a good balance of the centrifuge will minimize the risk of possible damage to the centrifuge and thereby damage to the tube that is in the centrifuge and contaminating the centrifuge. From the tube itself, per se, I don't see any need to handle it any differently from other PT or PTT samples. Dr. Sukesh, what is your take on this?
I didn't listen to you, Dr. Sukesh. Can you repeat that?
Yeah, this is basically PTT samples taken from COVID positive cases. What precautions should we take while handling them in the lab?
So, in our lab, we just treat it as a routine sample with the same precautions that we give for all samples as a potentially infective sample. We do allow pneumatic transportation. That's because the fear of sample leakage does exist, but we have made sure that because we get samples only from our staff which collect, so we have been repeatedly telling them to use the pneumatic, the evacuator tube systems, needle and needle holder. So the fear of, and thing is, there's one more secret that we have, that is we, during the COVID season, we decided that we will only distribute grainer tubes instead of BD tubes, because grainer tubes, when you open it and add sample and recap it, you can't just recap it, you have to screw it in. So that prevents sample leakage in pneumatic system. So that's one way, because pneumatic system, because we are working at less than 25% of our staff now. It's a manual transportation of samples manually is not going to be easy. We are using pneumatic system, but of course, we are treating PT and APTT samples the routine way, but with a lot of PP precautions.
Thank you. I think that I need to clarify there. The question earlier asked about VTM to be transported on the pneumatic tube.
Yes.
I agree with you that coagulation tubes can be sent on the pneumatic tube, but the VTM
but
should be handled.
When you were answering that question, your point on sample leakage in the that hit me really well, because I know that that's a possibility, and that can cause a lot of aerosols. Yeah.
Yes.
So with this, I thank all of you for such an interesting and very informative session on COVID-19. And also, most of them have cleared many of their doubts. Also, there are still many more questions keep coming. So in case we get more questions, we'll connect with you again and we'll share with you the questions and you can answer it separately. To all who are joining the session, the entire recording of the session is on YouTube, will be on Facebook Live and recording. So you can go and check it there. And also many of the questions can be answered later on. So I thank every one of you again. And I'm sure this is just a temporary moment and we'll be coming out of this very, very soon. And thanks again. Thank you.
Thank you.
Thank you, sir. Thank you so much, sir.
Thank you very much.
Good day. Thank you,
Good
sir. Happy birthday to Dr. Sukesh again.
Thank you. Dr. Sukesh, sir, please, last sentence.
Yeah.
So closing remarks, sir.
Okay. So I first of all thank all of you. Saturday afternoon is a good time in CMC because many of us have a later half of the day, but most of you must have also had planned for something like that. So actively participating for almost 2.5 hours in a good meeting. I thank all the speakers, Dr. Sujay and Dr. Anil, for having made such great presentations. Of course, I learned a lot from that too. I'm sure the whole audience did the same. And all those who have wished me greetings, I personally thank them for that and wish you safe and we can definitely win this war. Thank you.
Thank you.
Thank you so much, sir. Okay. Bye-bye.
Be safe. Yeah. Bye.